Just want to say greetings to everyone. Really thank everyone for coming to this pre-Astro GenesisCare educational program. On behalf of those who are tuning in from Zoom, just want to say welcome. My name's Wally Curran. I'm the Group Chief Medical Officer for GenesisCare. This is the second pre-Astro program for GenesisCare. We had a terrific program last year in Madrid. At that program, most of our United Kingdom speakers did it by Zoom, and we had some huge screen that I thought worked quite well. But it's great to have people together this year, and hopefully this will be an annual event at Astro. GenesisCare, as many of you know, is one of the largest providers of cancer care in the world, by far the largest provider of radiation oncology care. And our success, I think, really is about building and taking advantage of that scale. So having two of our nations come together for this program and having others tuning in via electronic media is really a good start for that. So I've been with GenesisCare a year and a quarter. When I think of the things that all of you are working on to really improve our care of patients around the world, it's very exciting. We have reorganized some of the physician governance, really starting from scratch in the United States and having a strong global Chief Medical Officer program with Escalada and Elliott. We've started Grand Rounds about a year ago, and I think you'll see a lot of great Grand Rounds programs this summer. And just a few months ago, we started some global research strategy meetings with strong leadership, both from the United Kingdom and Spain GenesisCare teams. Again, taking advantage of our global scale, I think can impact our care of patients locally. A lot of the work focused today is about how do we adapt the care of patients using radiotherapy and particularly using MR Linac tools that we'll hear a lot about. Right now, GenesisCare, in my view, is on the forefront of adaptive therapy with several units already in the United Kingdom, several units now in Australia, and a plan to build out a fleet both in Spain and the United States and add units in both UK and Australia over the next few years. Lots of exciting opportunities. To me, the way this will be most impactful is if we collaborate together, figure out what the critical questions are in every type of patient, and actually execute prospective research as it relates to it. Some of that research will be done by small teams at individual centers, but from that work, I expect we will have opportunities to do work globally. Love to hear, both formally and informally, from many of you how we can go from where we are to even a stronger position over the next months and years. So feel free to speak up. I'll be going with Brendan and the Spanish team to Spain next week. Michael O'Sullivan, our Global Chief Operating Officer, will be joining us at Astro in Spain, and he spent this week in UK. And I'll be going to UK later in the summer with Jess Lavelle, our Chief People Officer, as they call. So a lot of exciting things going on. Want to thank all of you for being here. And I want to turn the program over to Vladimir, who will introduce the first speakers. Great, thank you.
Thank you, Wally, for the introduction. I'm Vladimir Suarez, radiation oncologist and deputy CMO in GenesisCare Spain. MRI Linac is coming in 2023 to Madrid, Spain. So it's really excited. We are so with enthusiasm because this is growing. I would like to introduce some key Spanish team as our CMO, Escarlata Lopez, some leaders of CRGs as Dr. Jose Vegara for the neurology CRG, Dr. Elena Morena, research CRG, Dr. Marcos Guijarro is our member of the clinical strategy group, And also is our general manager, Brendan Capel, and Cristina Cordon is our development business manager. Thank you, and all that other members that came from Spain. Thank you so much for your presence. About 1 month ago, we were in UK, visiting the Cromwell and Oxford unit to see the MRIdian and how our colleagues in UK are working with the MRI Linac technique. It was really interesting, and we really do learn how to work with this amazing, accurate, and modern technique. Thank you to our colleagues there, because we feel really comfortable and really excited to work close with them. MRI Linac in Madrid is the start of a really GenesisCare building an European MRI Linac network. So we are going to close as a global European group with our colleagues in UK. This technique will bring the patients the possibility to have accurate, ultra high perfectionate treatments, and also short and with a good local control in the tumor. So we are really excited to have this in Madrid. Also, I have to say thank you for the presence of our colleagues of UK. They're really expertise and experienced doctors in all that GI, prostate cancer, lung cancer. So many thanks to them to be with us, and we are going to learn about you. Only to say we have to respect the timings in the presentations. After presentation, we are going to have a coffee break, and also the Q&A timing for any presentation. So the first one will be Dr. John Conybeare, an expert, a radiation oncologist expert in lung and breast cancer, who is going to start the first presentation. Thank you.
Much.
Good afternoon and welcome to the symposium. I'm Vini Isila, consultant clinical oncologist with special interest in lung cancer. I'm also a core member of the SABR and MRL team at GenesisCare UK. I would like to thank you for the opportunity to share an interesting case of pulmonary fibrosis we had recently treated at our Oxford Centre. Patients with pulmonary fibrosis are considered high-risk candidates for radiotherapy due to an increased risk of radiation pneumonitis, which is further complicated by acute exacerbation of pulmonary fibrosis. The risk of radiation pneumonitis has been estimated to be up to 30%, especially in patients with idiopathic pulmonary fibrosis. Fatal radiation pneumonitis is most commonly observed within 2 months of completion of radiotherapy. Grade 2 radiation pneumonitis has been reported in up to 50% of cases with any level of interstitial changes detected by lung CT prior to radiotherapy. Our patient is a 71-year-old gentleman with a history of scleroderma. He presented with a 3-month history of progressive shortness of breath and had a HRCT done to look for pulmonary fibrosis secondary to scleroderma. The HRCT demonstrated bilateral basal fibrotic changes in both lungs, which you can see on the attached images. The HRCT also showed a 4.5 centimeter right lower lobe opacity concerning for malignancy. He had a biopsy of this lesion, which confirmed this to be a squamous cell carcinoma with a PD-L1 expression of 2%. The pulmonary function test showed an FEV1 of 68%, FVC of 72%, and a TLCO of 30%. The HRCT also showed extensive pleural calcifications in the right hemithorax. His staging PET-CT showed the right lower lobe opacity to be FDG avid, with no evidence of nodal or metastatic disease. He was discussed at the lung MDT, and the plan was for observation, as he was considered as a high-risk candidate for all modalities of treatments including surgery, radical radiotherapy or systemic therapy due to the significant risks involved. During this period of observation, he gradually became symptomatic with an intermittent cough and a pleuritic chest pain. He had a repeat CT which showed an increase in the size of the mass to 5.6 centimeters. He had a repeat PET scan which confirmed the growth and avidity of the primary tumor, but still showed no nodal or distant metastasis. He was rediscussed at the lung MDT, and as he was symptomatic at this point, it was considered that he would be referred to the Sabre MDT to discuss the option of stereotactic radiotherapy to the primary lung tumor to maximize local control. When I reviewed him in clinic, he was reasonably well in himself. He had no significant limitations in daily activities, and there has not been any significant change in his exercise tolerance since the diagnosis of pulmonary fibrosis. He was of a performance status 2. He had no other significant comorbidities. He was not on any regular medications, including steroids or any other therapy for scleroderma or pulmonary fibrosis. I discussed the diagnosis of a large localized tumor, of which he was symptomatic, and the treatment option of stereotactic radiotherapy to maximize local control and delay disease progression. We had extensive discussions over 3 consultations on the benefits of local control versus the risk of possible fatal pneumonitis. I discussed the option of treating him on the MR Linac to take advantage of breath hold delivery to reduce the treatment volume, thereby reducing the amount of lung radiated, and also to take advantage of daily recontouring and plan reoptimization to maximize target coverage and to keep the organs at risk well within the planned tolerances. He was very keen to consider treatment as he was progressively getting symptomatic with a persistent cough and a pleuritic chest pain, and gave me his informed consent for Sabre on MRL. He was also consented for a higher risk of chest wall toxicity, including rib fracture and chronic chest wall pain. He was also aware of a slightly increased skin reaction given his history of scleroderma. He had a planning MR scan on shallow inspiration breath hold. The top image on the right shows the treatment volumes with the GTV contoured in blue and PTV contoured in red. The GTV was defined using the planning MRI supported by the planning CT and the diagnostic PET. All the organs at risk, including both lungs, heart, trachea, bronchial tree, esophagus, spinal cord, and chest wall, was defined on the planning scan. A 5 mm PTV margin was given. The prescription dose was 55 gray in 5 fractions, delivered on alternate days. The image at the bottom shows the dose distribution on the planning scan, with the bright red showing the 100% dose distribution and the dark green showing the 50% dose distribution. This slide shows the planned DVH summary, and you can see the PTV has been compromised to keep the doses to the lung, skin and chest wall as low as possible. However, you can see we could not keep the chest wall dose within tolerance without compromising the GTV coverage, and on balance, we decided to exceed the chest wall tolerance to maximize local control. The lungs were kept well within tolerance with a mean lung dose of 5 gray and a V20 of 9.4%. He was well aware of an increased risk of chest wall toxicity and a possibly exaggerated skin reaction. This slide shows the treatment volumes and the dose distribution on the planning MR, and also the daily adapted treatment volumes and the re-optimized dose distribution from day 1 to day 5, acquiring a plan with the target coverage very similar to the base plan and keeping all the organs at risk well within the planned tolerances. This slide shows gated delivery in shallow inspiration breath hold. The target here is defined in red. The yellow contour around it is the boundary margin, which is very similar to the PTV margin in general, which is about 5 millimeter. The patients are able to see this image on the screen during treatment and are requested to hold their breath in such a way to keep the red contour within the yellow contour. When that happens, the beam is switched on, and the beam remains on as long as the red contour stays within the yellow contour. The beam is switched off when the red contour moves out of the yellow contour when the patient starts breathing freely. The treatment is delivered in several breath holds depending on the capacity of the patient to hold their breath. He was able to hold his breath without any difficulty. The tumor motion was about 1 centimeter, and treating him in inspiration breath hold definitely reduced the treatment volume to reduce the treatment-related toxicity. He was supported with dexamethasone 4 mg once daily during treatment with PPI cover. He was also given inhaled steroids for 3 months with prophylactic doxycycline to reduce the risk of radiation pneumonitis and the risk of intercurrent infections. He was advised on regular skin care during and post-treatment to reduce the risk of skin reaction. He had weekly telephone reviews to check for toxicity. He did report an erythematous skin reaction during his follow-up at week 6, which then progressed to a dry desquamation over the next couple of weeks and completely resolved in the following weeks with a careful skin care routine. He did not report any symptoms suggestive of radiation pneumonitis during his weekly follow-ups. He had a chest X-ray at 4 weeks to assess for pneumonitis and had a CT scan at 3 months to assess response. His CT scan at 3 months showed a reduction in the size of the tumor to 3.5 centimeters with no evidence of new disease. The images on the right show pre-radiotherapy tumor size on the right with a reduction in the size of tumor at 3 months and a further reduction in the size of the tumor at 6 months. There was no significant deterioration in the interstitial changes post-radiotherapy at 3 months or 6 months. Clinically, his exercise tolerance remained relatively stable. The presence of any level of interstitial change suggests a risk of fatal radiation pneumonitis. There are no dose limitations or recommendations for safe radiation treatment of lung cancer in pulmonary fibrosis, irrespective of whether a conventional fractionated radiotherapy or stereotactic radiotherapy is considered. There are no reliable predictive factors to accurately assess toxicity in this complex group of patients, though a number of predictive factors including the percentage of involvement of the lungs, baseline pulmonary function tests, performance status, exercise tolerance, and biochemical factors such as LDH and CRP are widely used to assess toxicity. Radiotherapy for patients with pulmonary fibrosis and lung cancer requires an individual approach depending on stage, PFTs, exercise tolerance, and the prognosis of the primary disease. Decision-making should always take into consideration the potential benefits and risks, and should be carried out by a multidisciplinary team comprising of a chest physician and a radiation oncologist. The potential benefits and risks of treatment should always be thoroughly discussed with the patient prior to signing the consent form to ensure an informed consent. Treatment on an MR Linac with reduced treatment volumes, daily adaptation, and gated delivery appears to offer some advantages in treating these high-risk patients with a relatively low toxicity. I would like to take this opportunity to thank the patient and his family and the GC UK MRL team for their support. Thanks for listening.
Good afternoon. So my name is John Conabeer. I'm a consultant clinical oncologist, and I'd like to thank GenesisCare for kindly inviting me to chair this session on thoracic malignancy and the benefits of MRL in the management of this disease. So I'd like to thank Dr. Vini Eshill for opening our session this afternoon with a very interesting case on a complex patient who benefited from being treated using MR-guided stereotactic radiotherapy. So we also have two further speakers this afternoon, which I'll be excited to introduce shortly. Both speakers will be presenting live to you within the auditorium this afternoon. At the end of the three talks, there will be an opportunity for questions, and we'll be holding a panel discussion amongst us all about the challenges we face in treating lung cancer and how MR-guided stereotactic radiotherapy is helping us to achieve things that we simply couldn't do previously. So without further ado, I'd like to introduce our second speaker, Dr. Drew McCannachie, who's Professor and Chief of Thoracic Oncology at UCLA, and he'll be talking this afternoon to us about the new features in the MRIdian A3i and its functionality, which we hope will benefit patients with lung cancers. So without further ado, I'd like to introduce Drew to the stage to present his talk. Thank you.
Thank you. See, my microphone is working. So my task is to talk about the upgrade that is coming. So if you're a never user, you won't have to go through the transition of an upgrade. But if you're a current user, you get to see kind of what your new system is going to look like. So my disclaimer, I have been paid to make this presentation, although I generally believe my reputation is more important than the small remuneration for giving a talk. So I'll be as honest as I can with you. And then here are my other consulting that I do. I see myself less and less as a modality physician, although I do deliver radiation therapy. I try to take always a comprehensive approach to our patients and provide the right treatment for them, which sometimes might not be radiation. So as a reminder, stereotactic body radiation therapy was developed in the 1990s, and I emphasize this to say that those who are still not using it, how much longer do you need to wait? It's been 25 years. The safety of it was established in elderly and frail patients. So if it's safe in those patients, imagine how safe it might be in younger, healthier patients who may otherwise be offered surgery as their upfront treatment. And the local control rates, you see different numbers, but generally you can quote up to 99% tumor control, depending on the density of the lung tumor. So if it's a small, mixed, solid and non-solid, Japanese data, actually one publication shows up to 100% our tumor control rate. So the control rates are high, but they're dependent on the textures of the tumor as well as the size of the tumor. These are the latest trends that I'm aware of. This is a database study that we did when I was at Emory, 200,000 patients who underwent lung surgeries, and then we looked at kind of overall about 363,000 who had stage 1 period. And these are at 8 American College of Surgery accredited sites. Those are the sites that report to the NCDB data bank. So it's a large representation of delivering of treatment in the US, but generally higher performing centers. And what you can see here is that surgery between 2004 and 2016 did have a little bit of a climb as far as the ratio of cases going to the operating room, but then you've seen this gradual decline as the blue proportion of the bar graph shows the increased uptake of SBRT as a treatment. And this increase started right around 2008 when the Bob Timmerman phase 2 RTOG 0236 trial was published right around that time. And in the green, you see conventional radiation, which unfortunately you still had about a quarter of sites in the US at these accredited sites still not delivering SBRT. What is it? Is it concern about toxicity, not having the right technology? The truth remains it's still not uniformly available, and I believe that machines like MRIdian do make clinics SBRT enablers. And one of the benefits we've also seen is in the red part of this graph. These are the patients who historically had no treatment at all for their stage 1 lung cancers. And so we're starting to see a gradual decline, so at least they're being offered something, because we have data that shows that while we wish that these older patients or believe they may not die of progressive metastatic lung cancer when not treated, about half of untreated people with stage 1 lung cancer do die of their lung cancer before they die of something else. So many times we do want to at least offer them some treatment. In this paper, we also saw this very symbiotic relationship of SBRT being available in a multidisciplinary clinic. So as time has passed, the red line here is the 30-day surgical mortality rate for stage 1 lung cancer. The blue is the 90-day, which is typically 2x. And as SBRT utilization goes up here in the gray bar graphs, you see this gradual decline of surgical mortality. Now, we did a very elegant statistical modeling to demonstrate that that downward curve of surgical mortality is actually independently associated with increased use of SBRT. So there's being a shift. So surgeons or the team as a whole is being more selective in who they're sending to the operating room so that surgery can continue to be a great treatment and have less and less harms and allow SBRT to take care of the borderline patients. So as we get more and more borderline patients referred to us, we're going to see less and less surgical complications and basically less complications overall for all patients. So what about this concept of offering SBRT instead of surgery for inoperable patients? Well, as you may imagine, this is a contentious topic because surgery has been the standard of care since the 1930s. We're almost at the century mark at this point. But we're seeing data that's really starting to question our belief that surgery offers the best hope for cure. So this was a report that's widely contested because it's a combination of two failed randomized trials. So they only had 58 patients total. But when patients were randomized, so they were healthy enough for surgery, and some got radiation, some got surgery in a randomly allocated fashion, the SBRT actually performed superior. Now, people will argue, well, the surgery arm underperformed, but I just say, just focus on the blue line. Look at the excellent survival outcomes when SBRT is given as the upfront treatment. This group at MD Anderson that ran one of those trials actually did a new trial, and I think all people who are delivering SBRT for lung cancer should be aware of this study. For me, it's the highest quality prospective trial, although it's not randomized, of operable patients who got SBRT instead. You're looking at 80 patients who said, yes, I know I should get a lobectomy as standard of care, but I want to enroll in this protocol. And this protocol actually was PI'd by Jack Roth, who's a thoracic surgeon at MD Anderson. And you can see that while there's two different journeys for a patient with operable lung cancer, either you go down to the operating theater and you're done in about a week, or you come as an outpatient and you're done in about a week. That down the road, you do have a couple more in-lobe failures in the SBRT arm, so a slightly different journey, but it does not compromise either survival or lung cancer specific survival in this match propensity cohort, where they really did the best that they could to match the patients that were prospectively being tracked at MD Anderson. So this is high quality MD Anderson surgery versus high quality MD Anderson SBRT, showing really no outcome differences. And I quote these data very comfortably with my patients. And then what's fantastic is that the risk of complications, the grade 3 toxicity in the SBRT was 1% at 5 years. And you see here that the surveillance, you do have some infield progressions and local regional failures, but again, does not compromise survival. So phase 3 randomized trials are ongoing to compare these two. While there were 5 studies that actually opened and closed prematurely, including this Mayo Clinic study that people don't talk about. They actually opened. It's on clinicaltrials.gov. I was able to reach the study team managers, and they unfortunately enrolled a total of 0 patients. The largest study that enrolled was 31 patients in the STARS trial, but both the Stablemates and the Valor trials are now just over 200 patients enrolled. Stablemates will finish at 258. Valor has to go to 670. Ours is a 5-year survival outcome measure as we try to assess kind of when SBRT may be an alternative to surgery. Now, when we talk about SBRT to avoid a lobectomy, there's pros and cons, and depending on who you talk to, they may have a different perspective. They may be excited about it or say, hold on a second, we're not ready yet. And how can a MRIdian help us get there? Well, so if you look at this, the right lung has 3 lobes, and then the right upper lobe here, you have a tumor that technically cannot be removed with a wedge resection. It's in the middle of the lobe, and you have to take the whole lobe because of a technical issue. Now, there may be a segmentectomy, but by the time you get these things out, maybe you might have to take 2 segments, and apparently there's no such thing as a bisegmentectomy. It's still scored as a segmentectomy. So when you're looking at these cases, you might want to ask how many segments were taken out. But at the end of the day, you could either take out the whole lobe or deliver SBRT into the middle of this lobe. And if it doesn't work, you can go back and do a lobectomy as a salvage procedure for possibly 1% risk of a local-only failure. That MD Anderson study that I showed, the revised STARS trial, in the 80 patients, there was only 1 that needed a salvage lobectomy. So what I want to talk about in this presentation is the importance of preserving the surgical option for salvage if needed. So here's one of my patients, operable. Surgical option is a lobectomy. It's too proximal. They can't necessarily get past the bifurcations of the, for a segmentectomy, you have to clamp 3 separate structures, the bronchus, the artery, and the vein. And if you're close to the central area, you kind of have to get it. You can't really tease them out. So that was the option to remove this very small tumor, and it just seemed to be too much treatment for such a small tumor. So we had a multidisciplinary conversation, and the patient ultimately wanted to do SBRT, but only if they knew it would be safe and that salvage surgery could be preserved as a backup option. And you see we're above the hilum, and I know that if I minimize the scar volume, that's going to minimize the risk of a surgical complication if salvage surgery is needed. And so why would I ever treat an IGTV volume if I can just treat the GTV instead? And as all of us in this room probably have some familiarity with, it is hard to do gating. It requires a lot of surrogates and indirect modeling, and the MRIdian really offers a simple class solution for this. I want you to think about the date of this publication. Here we are 15 years later. We know that it's better to treat smaller volumes, but controlling that motion is not easy with the currently available technologies. And for me, I think that MRI-guided therapy is fantastic. So I was a skeptic of MR technologies. I just joined UCLA a year ago, so I come at on the back end of this historical timeline. So UCLA first constructed their MRI-specific vault that currently is no longer needed in 2013, installs the machine. Your typical pictures, the crane bringing in the machine. The first patient was treated in 2014. It was a cobalt system at that time. And then in 2015, we were already doing gating and adapting by summer of 2015. So then around 2019, the MR conversion occurred, and there was some construction that had to be done at that time, but apparently VRA has overcome that, and we don't have to worry about this anymore. And we upgraded to 2.0 in 2020, so that was just a few years ago. And the first MR Linac patient was delivered just a few months before I actually got there. And so I get there, and I get to be there for the photo op for the first 1,000 patients who were treated and now involved with the A3i upgrade. And I think the reason I'm talking here is because I've gone to the headquarters to learn about what the A3i upgrade is going to look like. So many of you have seen these images, the fact that you can actually monitor in real time the tumor and its movement while the treatment is being delivered is a great breakthrough. You have multiple quality assurances to achieve the ALARA, which really should be an underlying principle of everything that we do, which it shouldn't be okay to treat larger volumes just to be safe. ALARA, I believe should be held as an important tenet at all given times. Here's one of my patients with an oligometastatic tumor sent to me, and the last thing I want to do is hurt this patient. So this tumor is big enough, I can clearly see this on the MR Linac, so I threw her on that machine and delivered 3 fractions. She's about a year plus out, no toxicities from treatment. The tumor is basically a little scar at this point. But the way that we do it is a simple 17-second breath hold. We contour just the GTV. Again, this is not an IGTV-based treatment. That's the gating boundary. It's only 3 millimeters. I continue to use a 5 millimeter margin, but let me tell you, when I'm watching the beam being delivered and I know where the tumor is, I'm starting to wonder, why am I adding 5 millimeters just to be safe? So maybe in some future date, we'll go to 3 millimeter margins. And this is the cine, of course, tracking, and you guys have seen these images before, just like in the last presentation. So what's new in A3i is you're going to be able to track these things in multiple planes. And so as you saw in the last picture, visualization can be a little bit difficult. And sometimes you may need to rely on surrogate organs as, instead of a fiducial, use a normal tissue organ as a surrogate. And with multiple planes, it increases the likelihood of not missing. We really can't miss. And as our comfort not missing increases, I think we're going to start moving to more and more 3 millimeter margins. So it's important for new users to be aware this is a new concept of how we deliver treatment. It's much more like being a surgeon in an operating room. So we have the MR-guided adaptive radiation therapy theater, which is similar to a surgical theater. So I actually did a full year of general surgery training. And in there, the team needs to know how to work together in concert, because if one person slows you down, then the whole process slows down. So optimizing the workflow actually, I think, is what explains this trough of disillusionment and the enthusiasm curve. So we get very excited, oh my gosh, I have MR Linac, I can adapt, until you get into that MR-guided adaptive theater, and it just takes so much time that things are not moving as fast as you want. It pulls you away from all the other things you need to be doing in your clinic. And A3i addresses this very nicely. So one of the beautiful things about the new A3i is that you have this, you just have to get here to start the video. So right now, you have to wait for one person to finish your task before the second person can do their task. And then a whole team has to wait for that second person until the third can start. And if you think about the tension that can create, right? Because now that person's being watched, everyone else gets impatient. And so now you can have 3 people working, or even more, working in parallel, showing that the physicist is doing their task while the radiation therapist is doing their task, and the radiation oncologist. And also now, we live in the pandemic era, you can be in separate rooms at separate consoles, and this speeds things up. It's just like being in a grocery store. If you have 3 lanes, you're going to get everybody out the door faster than everyone getting behind each other in 1 lane. And what does this look like? At the next screen. So the green box here will show the actual, activity that's occurring here, and they're labeled. This is the lead therapist. The radiation oncologist, meanwhile, is observing as the initial image is acquired and fusion is being confirmed. And then the group as a whole can look and decide whether to adapt or not, and we're going to adapt. So now I got to recontour the prostate. So the radiation oncologist is doing that task. The second therapist is contouring the femoral head at the same time. And then over there, someone else is contouring the bladder. Meanwhile, the physicist is doing whatever the physicists need to do for electron evaluation. And all of this will actually go a lot faster. So I think if we can speed up the adaptation that we need, also and Steve's going to talk a little bit about the high-risk central tumors. I'll let him speak about that. You're going to be much more likely to actually do that. And so now you're approving the contours, and after this point, you can get the plan ready more quickly, and all of us can finish our tasks, go back onto what we're doing, and ultimately get more patients through per hour and every day. And I want to leave you just kind of with a definition in case you were wondering why our phase 3 trial is called Valor. This is actually the definition of our study. It comes from the word that's on the Medal of Honor, which is the highest honor that's given to a military soldier in the U.S. And here the definition: great courage in the face of danger, and especially in battle. I don't know who the battle's for, if it's for us as radiation oncologists challenging surgery, or the patients who are agreeing to be randomized to these 2 treatments. Thank you very much.
Thank you, Drew, for sharing with us both your cases, but also the exciting advances we will see with the new upgrade in the ViewRay MRL. So our third speaker, before we take questions on the panel, is Dr. Stephen Rosenberg, who's an assistant member in the section of the Thoracic Oncology Department of the Moffitt Cancer Center. And he's going to talk to us this afternoon about how we can unlock the treatment of central and ultracentral lung cancers using MR-guided radiotherapy in the delivery of SABR. Stephen.
Thank you so much, and thank you for the two other speakers and Drew for a fantastic talk, and hopefully people can hear me okay. I was told to remind people who are at home to refresh your browser for the Q&A portion of this. Again, my name is Stephen Rosenberg. I'm the Director of MRI-Guided Radiotherapy at Moffitt Cancer Center. My email is on the screen, as well as the obligatory Twitter handle, so always feel free to catch me there. Here is my conflicts of interest, both for ViewRay and Novocure, for which I serve as a consultant. And here's the very specific language that I want to make sure that I put up here for you. So Drew had this same one in his talk, and it's what I often think about with MRI-guided radiotherapy, both Amara's law and the Gartner hype cycle. And Amara's law states that we tend to overestimate the effect of technology in the short run, but underestimate the effect in the long run. And so we have a new technology. I've been working with MRI-guided radiotherapy since 2014 at the University of Wisconsin. We all get very excited. Lots of fun things to do with it and things that we can do to improve outcomes. There's sometimes a feeling of almost peak of inflated expectations, and those of us who do research with MRI-guided sometimes feel like we're in the trough of disillusionment, but I think where we are currently is on the slope of enlightenment. I think this is where we're heading right now, and I'm really excited to hear the other speakers today to show us the exciting work that they're doing as well. So of course, let's start with the case. This is a patient of mine, a 77-year-old gentleman with a nodular mass, 1.7 centimeters posterior to the trachea, adjacent to the esophagus. EBUS was done, was consistent with a squamous cell carcinoma, no evidence of endobronchial invasion, and this is truly an ultracentral tumor. Ultracentral has no consistent definition. Moffitt has adapted the Nordic Highlands definition, which we're going to go through a little bit more in detail. But just to make sure we're on the same page about different definitions of central and ultracentral, we're all familiar with the Timmerman describing central tumors around the proximal bronchial tree and 2 centimeters around that area. Most recently, RTOG 0813 also reported their outcomes defining central as within or touching the high-risk zone 2 centimeters around the proximal bronchial tree or immediately adjacent to the mediastinal or pericardial pleura. For ultracentral, as shown here, our colleagues at AUMC actually described this originally as PTV overlapping the trachea or main bronchus. Again, at Moffitt, we sort of taken the Nordic Highlands definition, which is less than 1 centimeter from the proximal bronchial tree. And that's broken into 2 subgroups. Subgroup A, less than 1 centimeter from the trachea or main bronchi, or B being like lobar bronchi or other parts of the proximal bronchial tree. And so again, it's been almost 10 years since the Netherlands reported their first experience with SBRT in these very high-risk locations. They did 60 Gray in 8 fractions, and they had excellent local control, about 93%. However, cardiopulmonary toxicity couldn't be ruled out in 9 patients, grade 5. They have gone back and looked, and they said if you can keep the BED low for these organs at risk, less than 210, which we achieve in 60 Gray and 8 fractions, the risk of death is low, but something you have to really work towards. On the right of your screen is that same patient, which is the TRUFI sequence, outlining the tumor in orange, the PTV margin in blue, the trachea and the esophagus in green. So how does this fit this sort of patient? How do we think about this in the realm of the recently reported Nordic Highlands trial? And this was reported just about 1 year ago now. For those who are not familiar, this was a phase 2 trial that looked at 7 Gray times 8 fractions for 65 patients for tumors that are less than 1 centimeter from the proximal bronchial tree. No endobronchial tumors were allowed on this trial. Again, there was those 2 cohorts of patients, as I mentioned. Cohort A were patients less than 1 centimeter from the trachea and main bronchi, and cohort B were all other patients. As you can see on the top of your screen, there are 2 panels, panel A and panel B, and there's different stars there that are color-coded. If you look at, say, the blue stars, those are those patients who were treated on the trial who had no grade 5 toxicity and excellent local control. On the left of your screen is the patients who were in basically that high-risk group A. You see a lot of red stars. The red stars you see there are all grade 5 toxicities from treatment. And so in terms of the toxicity they saw in this study is that 34% of patients developed a grade 3 to 5 toxicity, and 15% of patients died of treatment. And so I like to really hit this home about why we think there's value in MRI guided in this scenario when this is the outcomes we're seeing with traditional based technology. And so what's the toxicity that people experience? It was mostly a bleeding-related death. It happened in the first 2 years, as you can see in panel A on the left of your screen. In terms of who experienced the toxicity, those in group A with tumors near the trachea and the main airways are the ones who most often experience this grade 5 toxicity. And again, it could happen usually within the first 2 years. And then the far right of your screen in panel C, what you see is that the distance from the tumor to those airways predicted toxicity. If you were between 0 and 5 millimeters, you had a very high risk of toxicity with treatment. So why did this toxicity happen in Nordic Hylas, and what can we learn from it, and how does it apply to MRI guided? Well, this was an editorial that myself and a few colleagues, both here in the room and I know that are watching abroad in JTO, that put in and looking through the Nordic Hylas and sort of saying why this toxicity happened. I also know my colleague Drew also wrote an editorial about this that appeared in the Red Journal, and I highly encourage you to check those out. But one of the reasons we think this happened is that the prescription for these tumors were to the 67% dose isodose line for central tumors, which led to 150% hotspots within that area, which we think are probably too hot for these very high-risk tumors. Also, there's a lot of heterogeneity in terms of their treatment setup from their margins from their tumor to the PTV, where the GTV or CTV to PTV margins was 4 to 7 millimeters in the transverse and 5 to 15 millimeters longitudinally. These are large volumes. On the right of your screen is a few patients that did die of grade 5 toxicity and where the tumor was located with their plan. There were some other things that were concerning about the planning process for this trial. The contour of some critical OARs were not mandated. For example, lobar bronchi, great vessels. Also, luminal OARs were drawn away that did not include the wall of such organs, which we think is critical for optimizing, making sure there's no hot spot in the wall of critical airways. So overall, not contouring or placing dose constraints on the overlapping ipsilateral lobar bronchus, only contouring luminal components, high doses to large volumes all probably contributed to the toxicity seen in this study. So the approach in Nordic Hylas makes an assumption. The assumption is that treatment planning approach, that there's really not a lot of change between intrafraction and interfraction in terms of our dose delivery for these patients. And I think it's really hard as radiation oncologists to get over this hump in that we spent all this time making a fantastic DVH for our patients that we were going to deliver, and going through all the nuance of it. And then what we actually deliver, which is what we think we're delivering, has a real disconnect there. And for those of you who know John Bayouth, again, I trained at University of Wisconsin, fantastic physicist. He used to say there's lies, and dosimetry. And so that's what I really think about here. And on the right of your screen is a figure from Dr. Lauren Henke's phase 1 in ultracentral lung tumors. And why is this such an important study? This was actually taking the original radiation plan for these ultracentral tumors and applying it to the anatomy of the day and saying how often we were violating organs at risk. And all those red dots you see is just the original plan applied to the anatomy of the day and how often we were not meeting our constraints. And these critical organs, the esophagus, the trachea, the heart, these are all critical structures for these patients. And so this opens the door, and what does this open the door to? It opens the door for adaptive therapy. And so what is adaptive therapy? I think everyone here is familiar, but just in case, it's changes in the radiation plan to account for the functional or physical changes of the person's tumor or normal anatomy each day. It actually gives an opportunity, the opportunity for personalized medicine in radiation oncology. And so here's again a figure from Dr. Henke's paper, the phase 1 in ultracentral lung tumors. And you can just see on the bottom of your screen the DVH. The solid line was before adaptation, the tracheal Dmax, and the dotted line was after adaptation, how much they were able to bring the Dmax of the trachea down with this approach. So I think some of the first reports on this were Dr. Fanazi and our colleagues in Amsterdam who just really led the way since they came online many years ago. And this was their first report of central tumors, and they used the definition, the International Association for the Study of Lung Cancer definition of central with PTV overlapping at 2 centimeters of the isotropic expansion of any critical mediastinal structures. This was the location of tumors that they treated to start in their first experience. This was 25 patients. And in terms of what they did was mostly 60 gray and 8 fractions or 55 gray and 5 fractions. And they were adapting the vast majority of their treatments both to improve PTV coverage and to decrease dose to critical OARs. And so there's very few ultracentrals in this first initial experience, but still some that would have fallen into that category. This is just a show in terms of their 25 patients that for the vast majority of them, they were able to improve PTV coverage, going from the sort of the dark predicted to the re-optimized dose they would have received. And again, showing that the goal of improved PTV coverage is from these box plots from the original predicted versus the re-optimized dosing, and how they were able to achieve a BED of greater than 100, which we all know in lung SBRT is the magical number, to improve local control from 71% of their fractions to 94% of their fractions. I think this is the most interesting one, their most recent publication. Again, Dr. Fanazi, again, the group out of the Netherlands who've just done a fantastic job here. These are high-risk tumors. There was 54 patients with primary or metastatic lesions treated at 7.5 gray times 8, or 11 gray times 5. For central patients, patients with ILD or re-irradiation. In terms of the re-optimization, 91% of their fractions were re-optimized either to decrease dose to critical OARs or to improve PTV coverage. A few examples of the different patients are shown at the top of your screen. In terms of who was on this, I would just emphasize that about 1/3 of the patients in this study would have met the Nordic Hylas definition. So it at least gives you some sense in terms of out of their 54 patients, about 1/3 would have probably fallen within that region. And what they saw with their approach was excellent local control at 12 months was about 96%, excellent OS and disease-free survival. But I think the part to me that's most critical is that there was no grade 4 or 5 toxicity. And again, with at least 1/3 of their patients that would have fit Nordic Hylas, you would have expected to maybe see some if this was also going to be an issue. But I think with adaptation and gating, we're just not seeing that same toxicity. So let's go back to my patient. So the PET scan reveals this is the only cited disease. Depending on where you are in the world or where you are even in the United States, there's all different types of fractionations you can choose from. Again, we sort of adapted the Netherlands fractionation at Moffitt of 60 gray and 8 fractions. And of course, how to treat these is also being tested in ongoing classic Linac-based studies in the Lustra and Sunset trials as well. So we prescribed 60 gray and 8 fractions. And again, we use a PTV margin of 3 millimeters. So our PTV margin equals our region of interest margin of 3 millimeters as well. We want 95% of the target to be within that boundary. 7 out of their 8 fractions were adapted, most often secondary to esophageal dose. So why do we need to adapt off the esophagus and the proximal airways in ultracentral? And hopefully, again, going back to Lauren Henke's study, where they took, again, the plan of the day and applied it to the original plan and gave it to the anatomy of the day, you saw how often we were violating organ at risk constraints. And here's an example of one of my patients who had, again, an ultracentral tumor. On the left is the original plan. And in fraction 2, you can see the esophagus and the trachea has slightly shifted before I've done any recontouring relative to that. So again, in terms of where you're placing your hotspot for the critical OARs, or for the esophagus where we really try to keep the dose down, this can be a real critical part of the patient's treatment. And this is because we try to, in that 8 fraction regimen, really try to keep the esophagus dose low. We try to keep a D1cc less than 40 gray, because the risk of late toxicity there is only about 1% if you're able to achieve that. So this is my patient, 7 months follow-up with significant post-XRT regression. He had minimal odynophagia helped by PPI after treatment. He has a history of GERD as well. No other toxicity was noted. He's otherwise doing well, actually much further out than this at this point. So I will make a plug, if you were here at Estro or to log in, that we are going to be presenting our experience from Moffitt on Sunday, May 8th in the Prof papers about central and ultracentral tumors with MRI guided. I don't want to spoil it. Maria Sandoval is a resident who works with me, and so she'll be presenting our data. At least we'll sort of tease the fact that most of our patients would have met the Nordic Hylas definition of ultracentral, and we're really excited about the outcomes that we've seen there so far. I think I'll also plug that I think, as Drew alluded to before, prospective data is going to be so important going forward. And there's going to be this Lung STAR trial, which is a phase 2 for some of these higher risk patients. Rupesh Kocheta at the Miami Cancer Institute and ourselves at Moffitt Cancer Center will be opening this up hopefully within this year. And we're hoping to validate some of these retrospective experiences with prospective data as well. And I think that, though there's a lot of benefits to MRI guided, there are also challenges here. And this was a review that one of my chief residents, Dr. Alston Sim, wrote with me, looking at both the pros and cons of MRI guided in lung cancer. If you're interested in looking at some of this going forward, he's going to be actually going to Ohio State for a position. But I think there's a lot of advantages, but there's some challenges as well. And as programs come online, a lot of us who have had experience with lung are always happy to help you try to deal with some of those challenges. There's one other area that we don't talk about in MRI guided that I think is a really exciting area that we're really working on at Moffitt, which is taking advantage of the imaging here. I work with both Bob Gillies and Issam El-Naka in our Department of Machine Learning, and when we do have patients who are getting an MRI every day, can we take advantage of that to understand what's happening inside the tumor and actually predict who's going to fail and who's not, and do radiomic-based painted SBRT. I think it's a really exciting area that we're really starting to delve into at Moffitt. And we're actually now learning some deep learning approaches with a deep neural network that predicts tumor failure based on changes in the GTV with MRI guided. And our early experience show with an AUC of about 0.74 of this deep neural network approach, which is going to be at AAPM this year, showing that we can predict failure. Our updated model, which we're actually submitting upcoming, is actually about 0.85 with external validation of an outside data set, which I think is a big part of predictive radiomics and deep learning. So we're really excited about this, and it's another part of MRI guided that I think we need to explore more and more. So where are we on the graph? I'll let you sort of decide as you hear presentations today, but I am hoping that we're towards the slope of enlightenment. In summary, central and ultracentral lung tumors have a narrow therapeutic window for SBRT or SABR. The HILOS trial highlights the need for both advanced radiotherapy techniques and margins to safely treat these tumors. The advantages of MRI guided include small margins, real-time gating and tracking, and on-table plan adaptations for anatomy of the day. And the challenges ahead for MRI guided include connecting the biological and the imaging data as well. And I think it's a really unique area we'll also see more and more work from going forward. I have a lot of collaborators here in the room and abroad and all over the United States, and it's just a pleasure to work with all of you, and I really appreciate the opportunity. And of course, the obligatory family photos with wife and kids and parents and all that. So I think we're gonna be taking questions towards the end, but thanks for your attention.
Could you go, Drew? Could you go, please? Okay. Preguntas.
Dime tú, ¿qué moderas de salir? Di que no hay preguntas.
So can anyone hear me?
Yes.
Great. Hi. First of all, just like to say thank you to Beanie, Drew, and Stephen for 3 excellent talks, really demonstrating how things have moved on in the world of lung cancer radiotherapy. If I could just take the opportunity to ask 2 questions. The first one, maybe to Drew. Drew, when it comes to tumor size, do you have an absolute cutoff where you won't consider using MRL, or do you give the patient the opportunity to have an MR sim to see whether it's trackable and then proceed with MR-delivered therapy?
I initially thought you were asking about the upper limit. I believe the question is about the lower limit. Is that correct?
That's correct, yes.
Yeah, so it has to do with the solidity of the tumor, and so the more solid component, the more likely we're going to see. We have not come up with a predictive model, so I will often go ahead and try it, even when there's skepticism. And depending on what we see at the machine and being able to window the cine, then we decide whether it's a view rate. I call them view rate failures. And so I don't have a limit, but I feel like once you get to 13, 12, 11 millimeters, you just can't see it. And some of these actually, if it's really ground glassy, you actually can't even see them on a cone beam as well. I've had at least one patient I couldn't see either on the MR or the cone beam. I sent them for a percutaneous ablation instead.
Thank you. And then Stephen, in your talk towards the end, you talked about the opportunities for MRL. And I wondered, have you looked at its potential benefits in adaptive delivery for inoperable stage 3 cancer, obviously a more advanced disease?
Yeah, I think the challenge is some of the dosimetry currently with the MRI Linac about our stage 3. We did do some dosimetric studies early on, and we just didn't find that was going to probably be helpful for us, though we have worked on the idea of actually a boost protocol that we're still trying to work out and develop for our stage 3. So say if they go through, say their normal 60 gray in 30 fractions on a conventional Linac, but then actually provide an additional boost to very small margins, and hopefully you've had some actually volume reduction at the very end of treatment, with the idea of both improving local control and also, potentially in their durvalumab that they'll be getting afterwards. But that's still in development right now.
Is it okay if I'm the contrarian?
Yeah, sure.
So the dosimetry may be inferior, but I think that if we generate enough demand for this, Dr. Dempsey and team can maybe get us prioritize better optimization plans. But the one thing I would say is that regardless of the plan, that the IGRT really might create a big opportunity for us that will have a meaningful impact. And it's meaningful because we are seeing some very severe pneumonitis complications. Today, you don't just give 6 weeks of chemoradiation. You give 6 weeks of chemoradiation and then 1 year of durvalumab. There's actually a paper being presented here this weekend that shows that the additive contribution of that drug, so we have to minimize the amount of normal lung injury as much as possible to make sure that the patient has a safe journey with the drug, the durvalumab immunotherapy afterwards. And if we add up the number of millimeters we're currently adding just to be safe, it's over 20, 25, sometimes 27 millimeters on the GTV. You take the GTV, you don't have a good gating system, so you do IGTV, 10 to 15 millimeters on average, sometimes even more. Take the 10 to 15, now you're adding 7 to 8 more millimeters just because you think you should add a GTV margin. And then on top of that, you generally add about 7 millimeters, sometimes 10 more millimeters just to be safe. And you're now in the 25, 27 millimeters. What if you just treated the GTV with MR-guided gating, automated gating, in 2 planes, because these large locally advanced tumors have bizarre shapes and they change during 6 weeks, and you only add 5. Wait a second. You went from 27 millimeters to 5? How can you do that? Well, there's data that shows that this whole CTV margin expansion that we're doing also probably is overkill as well. And so this probably should be done in a prospective trial. But I think that would dramatically, if you think about the R-cubed factor of volume of normal tissue that's going to get treated, you really may be able to further reduce the incidence of pneumonitis. And there's actually another paper, in that paper I was discussing earlier, there's an advocacy for maybe proton therapy to reduce the risk of durvalumab-associated toxicity. So I think that the fat lady hasn't sung yet on this topic, and we should consider possibly using. Now, right now I'm being told, please don't put a patient on the machine for 6 weeks because UCLA has become very exciting place after the Mirage trial for prostate cases. But I hope as workflow gets better, we can actually get these 6-week patients on that machine.
I think to Drew's point that if obviously you can shrink the margins significantly, then you can overcome the dosimetry. It's just a question of, I think doing that on a prospective trial would be critical if you're going to do something like that.
Yeah, so I think Dr. Dempsey heard my ask here.
Yeah.
our ask.
That sounds incredibly exciting. I know in the UK we'd certainly be keen to take part in prospective data collection in that setting. So any questions from the audience, please?
I see a hand. From Madrid, right?
Yeah, exactly. Elena Moreno. Thank you. Thanks. How about, I don't know if you listen to me?
Yes. No.
Yeah. How about your experience with multiple lesion or METs? Because I think, or I thought you just can gating one lesion at one time. So you should do at sequential time, or if you have, for example, 3 METs in one lung.
Do you want to start?
Sure. So I think for right now, in the system as it currently is, that's really a challenge. But as I'm sure with the new upgrade we're going to have, where you can track multiple things at once, then you're going to feel a lot more confident about the ability to deliver, 3 sites, for example. I think for right now, I usually assess motion in different planes. And so actually, I just finished a 2-site SBRT for somebody, but both the lesions moved almost in conjunction with each other. So I felt very comfortable with that. So I find it to be right now very patient dependent, but I think as Drew went through the upgrade, we'll be able to do a lot more of that for people who have 3 lesions, and I'll defer to him about any other comments about that.
Yeah, I think that the off-axis issue will define whether you want to try to do it in the same session or just get a new sim and realign and do the second isosensor through it. But we know this is an issue because patients with lung cancers get more lung cancer and more lung cancer, right? It's like popcorn in a microwave. First you get one here, and then one here, and then one here. And it's very important if we're delivering multiple sessions of SBRT to be treating the controlled motion, whether sequential or concurrent, at the same time.
Thank you.
Excellent presentation for Vinny, Stephen, and Drew. Drew, or maybe the three of you, even though we have low rates of relapse in field, MRIdian MR Linac guided radiotherapy could be an option, a really good option for reirradiation.
So I've absolutely done repeat SBRT, and this is actually even in, and I've run into people giving me a hard time about it, even in a central location. I've done repeat SBRT, and so I've absolutely done it, and I have at least had good outcomes with that so far. And you see from the Fanazi experience, they had some of those patients were also reirradiation at the end of the day. I think you have to be really careful about, of course, doses to OARs, and one of the things with the MRIdian system is, importing that and how you optimize that. At the global users meeting, there was a group of us talking about reirradiation and how people do it. The workflow, I think, is a little bit institutional dependent, but I think there is a good way to be doing this with the MRIdian system right now. So yes, I absolutely get referrals for repeat SBRT in high-risk locations with this technology.
I think your normal structures is the name of the game for reirradiation. So it depends on where the target is, where the radiation was delivered. And so there's probably every one of us has a personal comfort of where you wouldn't do it again. I really like surgery for salvage. I push the surgeon very hard, even if they don't want to go. I show them the plan. Look, don't worry. Especially older surgeon, in my experience, it's all glued in, right? Because I was large field, 60 gray, APPA for 4 weeks, and then off cord for 2 weeks, right? So look, this is not that. Let me show you the plan. So I really push surgery, but at the end of the day, some people, surgery isn't an option. So then you say, well, I'll treat maybe this close to the trachea. So I think with MRIdian and gating and real-time tracking, you might go a little bit closer to the trachea. So I think it does expand probably everyone's comfort level, at least a few millimeters.
Vinny, any comments from UK?
Yeah, we have kind of treated quite some interesting re-radiation cases, especially of the central tumor, with good results. So again, like you say, it depends on the location of the tumor and the performance status of the patient and what's next to it, and individual comfort levels of the radiation oncologist about where to go as well. I totally agree with that. So we've had some good experience, and I think we are reasonably confident in picking up cases for thoracic re-radiation and consider them on individual case-by-case basis.
Just adding that, I definitely think the MRL adds a degree of comfort to that retreatment. So having used other platforms, doing it on the MRL, just being able to see what you're doing so clearly is great.
I see one more hand over here.
Sorry. So I'm Daniela from Spain. In Spain, we were going to have the big three, the Linac, CyberKnife, and MR Linac. So if you have the big three for SBRT, how you choose what patient to go where? Because of the talk that you say, for my experience, ultracentral tumors, I will go to the MR Linac. But the peripheral tumors, where do you think these patients go? For the Linac, to the CyberKnife, to the MR Linac? How you choose that? And the second question that I have is, for operal tumors, how do you do with your surgeons? Do you do a combined session with the patients, or you have it like you go first, I go after? How do the patient choose?
So 2 questions. Why don't we take the first one first?
Okay, sure. So we'll start with the first one. I think, a lot of us have different choices in terms of the tumor. I think ultracentral, even central for us, we start to get borderline. When you're more than 1 centimeter out, we start, at least for us, starting to look at, we often will get a 4D CT at SIM, so you get a sense of the motion. If we're ultracentral by Nordic Hylos, they all go in the MRI Linac. Then after that, we don't place UD fiducials for us, so we don't use like any sort of fiducial marker aspect. So most of us things that are technology are either ITV based or gated via the MRI Linac. So that's just what our institution does and has. And I will say that if I think there's significant motion and central or peripheral, where my lung doses are going to be higher, or it's going to compromise doses to a critical OAR, that's really what it is. For these peripheral tumors that are low towards the diaphragm, where I get 1.5 or 2 centimeters of motion, and I have somebody particularly who has IPF that was presented today, or some sort of other significant lung comorbidity, I'm often thinking about doing that to reduce my normal lung aspects. So a lot of motion, or I think the 40 is going to compromise a critical OAR, even if they're not ultra-central, but they might be central. And I'll stop there and let Drew and everybody else comment on that part.
I think once you use the MR Linac, your eyes change, your perceptions change. I was a skeptic until I got to UCLA, and when I got there, the physics team wanted to take care of me. So I said, well, how come we're not doing gating on the other machine? We have 4 rooms, and all 4 have a different machine. So MRIdian is just one. And so we went through all the process of setting up gating and tracking, and 10 minutes became 20 minutes, became 30 minutes, and everybody was brainstorming, and everyone's really, really bright. And then I said, you guys seem not to be getting it. What if I just put them all on the MRIdian? They all, their eyes open, and they smile and say, yes, please, let's just do that. It's a much simpler solution to gating, not to mention from the patient's experience, the fiducials, there's a risk with fiducial, right? So it's a fiducial less. You don't need the fiducials to do it. For me, it's a hierarchy. I try all patients with MRIdian first because I know it's a superior machine. If it doesn't work, then I go down the stream to think about the other machines. I don't have a CyberKnife, so I don't know how I would weigh the two together against each other. The second question with regards to our Oppo patients. So unfortunately, I'm at a site where we're enrolling patients in the randomized phase 3 trial. But before that, the patients all come through the surgeon, right? So the multi-D team, one of the first things I did, so that's where I'm at the VA, I randomized the patients. At UCLA, the study's not open. I was able to get the surgeons to agree with me. Look, let's all have one message to the patients, please. We don't know which treatment's better, but we as a team can say, we all still prefer surgery. I'm willing to give you that I prefer surgery, but I'm not willing to say that I know surgery is better, because then it's a mixed message. And the whole team agreed, because our med-oncs, pulmonary, and surgeons all see the patients. And so I said, please, let's all give the same message. We don't know which treatment's better. But the patients are always seeing the surgeon, and when I talk to them later, it's great. The patient says, yeah, I understand that SBRT is promising and so forth. And then they ask me, well, what do you prefer? I say, well, here at UCLA, we do prefer surgery because we don't have as much evidence in the SBRT side. But I don't know. SBRT might be better. These are honest statements I think should be shared with the patients.
Ruth, thank you very much for that. So I think we're going to close this session now. I'd like to just thank all 3 speakers again for such excellent presentations, and also for the questions from the audience and at home, and hope you enjoy ASTRO 2022. Thank you.
Many thanks, John, for hosting this first session in lung cancer tumors treated with MRI-guided radiotherapy. Thank you, Vinny, Drew, and Stephen. It's an amazing presentation. Currently in Spain, we are not doing adaptative in any place in Spain. So I see a very good opportunity to treat patients without fiducial markers, because right now, the only way that we are treating tumors, reducing the margin. So amazing opportunity with MRIdian to treating adaptative tumors, mostly in complex patients, high-risk patients. Thank you so much.